So when patients come into the hospital with different various types of cardiopulmonary symptoms or disorders, we usually do something called a serum electrolyte test to assess or help us assess their cardiopulmonary status. So an electrolyte panel um, kind of gives us values on the different electrolytes that are in our blood work. So it's a blood test. Electrolytes are electrically charged minerals that help control the amount of fluids and balance the acids and bases in our body. So they also control like kind of muscle and nerve activity, heart rhythm, and other important functions. So an electrolyte panel or a serum electrolyte test is that blood test that measures these levels of the main electrolytes in the body. Oops, sorry. So sodium is an electrolyte or a positive or cation that helps control the amount of fluid that's in our body. It helps your nerves and your muscles work properly. Potassium helps your heart, is also a cation. It helps your heart and muscles work properly as well. Chloride is an anion or a negatively charged ion that helps control the amount of fluid in your body and helps maintain a healthy blood volume and blood pressure. And then calcium is also a cation that that helps with controlled neuromuscular activity. I forgot one on here, but bicarbonate. Oops, sorry. One. Oh my goodness gracious. Serious issues today. Back here. Okay. And then finally we have bicarbonate. CO3. Okay, and bicarbonate helps maintain the body's acid-base balance. It also plays kind of an important role in moving carbon dioxide through the bloodstream. So anytime you have abnormal levels of any of these electrolytes, that can kind of be a sign of a serious health problem, including kidney disease, high blood pressure, or it can cause life-threatening heart rhythms. So this test is kind of part of a routine blood screening or a comprehensive metabolic panel. So they typically will do these in the emergency room when any time a patient's coming in, along with like a CBC to look at complete blood work. Okay, so to break down the individual electrolytes, so sodium, like I said, is a cation. It's going to be positively charged, and it's going to, high levels of it are going to be typically caused by dehydration or diuretic use. So sometimes we give patients medications to cause them to lose fluid or excrete more fluid, and that is going to increase the concentration of sodium in our blood. Hyponatremia is usually from overhydration, so too much fluid staying in the body, which is diluting out the sodium levels, or increased secretion of ADH, that antidiuretic hormone, which is going to cause retention of fluid. Severe vomiting and diarrhea can also cause a loss of sodium, congestive heart failure, and renal failure. So hyperkalemia or potassium is another positively charged ion that's in our bodies. So potassium is plays an important role in the transmission of those nerve impulses for muscle contraction. It kind of serves as a main intercellular cation. So the concentrations of it in that extracellular fluid where the serum electrolytes are being measured is usually pretty low. So that's why it's quite a bit lower, you see, than sodium. Um, so if this, because the levels are already so low, small losses or increases in these values could have significant impacts on the patient's heart rate rhythm. Hyperkalemia is caused by acute or chronic renal disease, where we're kind of not excreting enough potassium into our urine, getting it out of our body, or alcoholism can also cause this. Hypokalemia is oftentimes caused by severe dehydration and vomiting or chronic renal disease. It's important to note that high dose beta agonist therapy can affect your potassium levels. So, a lot of times with patients who are in the hospital that have that are experiencing hyperkalemia, they will be given inhaled albuterol inhalation therapy to lower those potassium levels. And this is because albuterol stimulates kind of that intercellular shift of potassium. So it's going to help decrease those serum potassium levels. It's important to note that you need to use high doses. So, like, if a doctor orders, I've had doctors order this before. If a doctor orders like a unit dose of albuterol, that's not going to do anything. So it needs to be doses from somewhere between like 10 to 15 micrograms of albuterol to use to lower those serum potassium levels. And usually you can lower the serum potassium level by 0.3 to 0.6 milliequivalents within 30 minutes. So it's kind of an effective treatment. But again, you need to use it in high doses. And there's also side effects because albuterol stimulates those beta 1 receptors, which can cause tachycardia. So, also, it's important to note that not all patients are going to respond to albuterol for hyperkalemia. So it's usually something that they try, but isn't going to be the treatment for urgent hyperkalemia. Fluoride, serium chloride is kind of a major extracellular anion or negatively charged particle. It's kind of important for maintenance of that electrolyte balance, hydration, osmotic pressures. So, so conditions that cause the retention or loss of chloride are generally the same as those that cause the retention and loss of sodium. So hyperchloremia usually is from excessive chloride administration, like excessive amounts of fluids. Metabolic acidosis or diabetes insipidus. Hypochloremia is usually commonly found in cases of severe diarrhea or vomiting, metabolic alkalosis, adrenal insufficiency, severe burn patients, or if you get too much dextrose, IV dextrose. So calcium usually isn't kind of always part of like the true electrolyte panel, but I included it in here because it is an electrolyte and it exists in 3 forms of the plasma and is measured kind of as total calcium. So serum total calcium is frequently ordered and included in that comprehensive chemistry panel. So if your patient has hypercalcemia, that can be because of hyperparathyroidism, so your thyroid's working really hard, diuretic therapy, metastatic cancers or myelomas can also cause your calcium levels to be high. Hypocalcemia is from that hypoparathyroidism. Can't talk today. A lot of blood infusions can lower your calcium levels, and acute pancreatitis and vitamin D deficiency could also lower your calcium levels. Um, So typically when your calcium levels are going to drop, that's going to affect kind of your muscle contractions. So if your calcium levels drops, you might have like that feeling of tension or muscle constriction. Whereas like if your calcium levels are really elevated, you might have a lot of muscle weakness. Okay, and then finally bicarbonate. Bicarbonate is uh, um, the second most predominant anion in the plasma and a major component in the carbonic acid buffer system that functions to maintain our blood pH. And again, we're going to learn more about this in acid-base balance. So a number of methods are used to kind of determine this concentration. We are going to learn about it on ABG values when we're looking at arterial blood gas values. When you're looking at ABG bicarbonate levels, the normal range is a little different. So for here, it's 22 to 29, but on an ABG, it'll be more like 22 to 26. High levels of bicarbonate in the serum bicarbonate would indicate a metabolic acidosis, or excuse me, alkalosis, so greater than 29. And this can be because of a loss of what we call fixed acids. Um, so, so those fixed acids can be lost due to or loss of hydrogen ions due to vomiting, um, gastric drainage, or through use of a lot of diuretics that cause a loss of calcium, potassium, and fluid volume. It can also be caused by hypochloremia, which increases your hydrogen ion secretion and your bicarbonate reabsorption, or hypokalemia, which does the same thing, or hypovolemia, which increases your hydrogen ion concentration as well. Um, it can also be caused by the retention of bicarbonate ions. So that is, kind of a gain of a buffer base. So meaning that I've been artificially given sodium bicarbonate. So sometimes we do this to treat metabolic acidosis, and then we overdo it, and then we're in metabolic alkalosis, and we have too much bicarbonate running through our bodies. Metabolic acid. Oops, sorry. Metabolic acidosis is when your bicarbonate level is less than 22, and this occurs because of too much fixed acid buildup in your blood. Fixed acids are metabolically produced by, anaerobic metabolism. So if you don't have oxygen for metabolic processes at the tissue level, the tissues are going to produce lactic acid. That's those of you that run or work out, you might have had experienced lactic acid buildup in your muscles. That's what makes your muscles kind of sore and tense the next day, or after your workout. So that's because of that lack of oxygen for metabolism at the tissue level, and it causes that lactic acid buildup. So as lactic acid buildups in the body sends bicarbonate to buffer it. So those bicarbonate, but that bicarbonate is used up to buffer those acids, and that is than is overall reduced in the blood. Ketoacidosis happens in with diabetic patients. Again, that's a fixed acid that's produced in diabetic crises. It needs to be buffered by your bicarbonate level, and then in renal failure. Also, patients can go into metabolic acidosis by ingesting acids. So, like aspirin, if you overdose on aspirin, that is going to cause metabolic acidosis. Other types of ingestions of acids will cause the same thing. You could also have loss of bicarbonate through, GI loss, like if you have a lot of diarrhea or if you have a pancreatic fistula, that's going to cause a loss of bicarbonate from it getting excreted from the body. You can also fail to reabsorb bicarbonate in those renal tubulars, which is going to cause acidosis, or you can ingest like ammonium chloride or other types of hyper alienated IV nutrition that can cause you to be in metabolic acidosis. Okay, so that's just a kind of a quick overview of like serum electrolytes and a little foray into some of the metabolic acid-base imbalances.